To begin, let us acknowledge that Queen's University is situated on traditional Anishinaabe and Haudenosaunee territory. We are grateful to be able to live, learn, and play on these lands. We thank the Indigenous peoples of this area for their care of this land for thousands of years, and we hope to honor and respect them as we hold our virtual event today. I'd also like to take a moment to personally thank you all for joining our virtual presentation today. Our speaker this afternoon is Dr. Rachel Wambolt, who will be presenting on Lyme Carditis, 2023 update on clinical management. Dr. Wambolt is a cardiology fellow from Queen's University. She completed her medical training at Norwich Medical School in the United Kingdom, followed by her internal medicine residency at Queen's University. Her interests include clinical cardiology, Lyme carditis, and women's cardiovascular wellness. We will have Dr. Wambolt present, and then we will open to the questions from the audience. You can ask your questions by entering your questions in the chat box or raising your hand icon when the moment does arise. Please help us welcome Dr. Wambolt to the podium.
Thank you so much for that kind introduction. I'm just going to get my slides up here. Perfect. All right, we seeing everything okay? Good stuff. Okay, so thanks a lot for having me today. It's my pleasure to speak to you all this afternoon about Lyme carditis. And we're focusing specifically on some of the new research that's been coming out of our lab here at Queen's. So this is an update from a 2023 perspective. And I'm hoping to shed some exciting new ventures that we're looking into as well near the end of the presentation. Unfortunately, my mentor, Dr. Baranchuk, can't be with us today, but he sends his regards, and he's been instrumental in getting me involved and passionate about this topic. So thank you to him. I don't have any relevant disclosures when it comes to the presentation today. As for an overview, today we'll just start by a basic review of clinical Lyme carditis. And then we'll discuss the current recommendations in regards to diagnostics and management of the condition. I wanted to focus today a lot on new research because we have done similar talks like this in the past. So I wanted to bring to your attention today some of the research that we've done looking at long-term follow-up of our patients with Lyme carditis. The research that we've published recently on Lyme-related cardiomyopathy, and then give a shout out to some of the upcoming projects we have. All right, so Lyme disease, as we know, is a spirochetal infection caused by Borrelia burgdorferi. While there are many types of species of ticks in Canada and the US, as well as in Europe and Asia, in Canada and the United States, it's primarily the black-leg tick, otherwise known as the deer ticks, that carry the infection that causes Lyme disease. In order for the infection to be transmitted, the ticks do need to be attached to their human hosts for 36 to 48 hours, sometimes up to 72 hours. 95% of the Lyme disease cases are reported between the spring, summer, fall months, so April to November, with generally a peak in the summer. And that makes sense because that's when Canadians are spending their most time outdoors. This picture highlights the highest risk areas in Canada. Many of those areas lie along the Canadian-US border, but as we look at the infographics here comparing 2020 to 2022, we can see that there has been some extension in some of the other regions of Canada. Specifically, if we look out to some of our eastern provinces, we can see here that there has been a spread of the at-risk area over the last 2 years out into Nova Scotia and New Brunswick. Returning to Canada as a whole, the incidence of Lyme disease has continued to rise in recent years in Canada. That would be in the exception of 2020, and we all know what happened that year. So probably not as much time outdoors. The numbers from 2022 are just preliminary at this point and are probably underestimated. So we'll see what happens with those numbers as the year sort of shakes out. As we know, there are 3 stages of Lyme disease identified in the literature. First, we have the early localized disease, which occurs days to weeks after the initial infection. This is characterized by the erythema migrans rash, which is that classic bullseye pattern, but can have varying appearances and can look differently in patients of different ethnicities as well. Patients will often have other accompanying symptoms, including fever, fatigue, malaise, lethargy, and headaches. Moving on to early disseminated disease, this occurs weeks to months after the initial infection. It can be characterized again by erythema migrans, but you can get multiple lesions at this stage. And there can be development of both neurological complications as well as cardiac symptoms, which will be the focus of our presentation today. And then we have the late disseminated disease, and this often occurs months to years after the infection. It's characterized by intermittent or persistent arthritis. Patients can get neurological issues. And we're just starting to look into the possibility of some long-term cardiac sequelae that would be found in a late disseminated stage as well. Lyme carditis, it's a term that we use to describe the cardiac manifestations of Lyme disease as a whole. We speak a lot about the effect of Lyme disease on the electrical conduction system of the heart, but actually the infection can manifest in all parts of the heart, including the muscles, the inner membranes of the heart, the blood vessels, and the heart valves. And so as we're learning more about cardiac or Lyme carditis, we are starting to see some of these more general manifestations. But overall, conduction abnormalities are still the most common, and they do represent about 4 to 10% of untreated patients. 1% of the 4 to 10 that develop Lyme carditis, As I said, AV conduction or atrioventricular conduction blocks are the most common electrical abnormality. And if we look at the diagram here, basically what we're talking about is blockage of the electrical conduction from the top chambers of the heart through this AV node and into the bottom chambers of the heart. And patients can manifest at different stages. So if there's just delay of that signal through the AV node, they can present with what we call a first-degree AV block, and patients may not be symptomatic at this stage. But the trouble is that they can progress very quickly to a third-degree block, and that can be life-threatening and can cause symptoms such as syncope, lightheadedness, dizziness, etc. We're fortunate and unfortunate to, I guess, live in Kingston, which is an area that's surrounded, is endemic to Lyme disease. So we do have the opportunity to invest a lot of time and research into Lyme carditis. I wanted to briefly summarize some of the early key highlights coming out of our lab. So back in 2017, we put out a case series on the topic of Lyme carditis. And we looked specifically at ECG presentations of that atrioventricular block. And later, these research studies led the way for us providing guidance to the rest of the cardiology world and the medical world in regards to how we should assess and manage the patients presenting with Lyme carditis. In 2018, the lab published a review of the suspicious index in Lyme carditis, and this is called the Silk risk score. And it's been very useful clinically to assess whether somebody presenting to hospital with a heart block might be presenting because of an infection with Lyme disease. In clinical practice, we use this algorithm CoStar. It helps us remember all of the variables that we want to include in this score. So we're looking at constitutional symptoms, which include fever, malaise, arthralgia, dyspnea. We look to see if the patient either works or engages in a lot of recreational activities outdoors and in an endemic region. We know that males are more commonly affected by Lyme carditis, and so there's a point for sex, tick bites, age less than 50, as well as presentation with the typical erythema migrans rash. Subsequently, we published Dr. Young and then Dr. Baranchuk. They published a paper in JACC, which was an outstanding systematic review looking at the diagnosis and treatment of Lyme carditis. And then within this review, they used the Silk score and incorporated it into an algorithm, which helps clinicians kind of go through how to diagnose and manage these patients. So we'll briefly go through the steps here. So when patients present with high degree AV block, it's important to consider Lyme carditis as a cause, especially if they're young and male. And so we use the silk score to risk stratify them. So if a patient has a score that's more than 3, that will put them in the intermediate or to high risk stratification scores. And then that patient should be started immediately on empiric intravenous antibiotics, as well as admitted to hospital for monitoring. And at the same time, we'll send off their serological testing for Lyme disease. If the patient has a low heart rate, so they're bradycardic when they come into hospital, they need to be on cardiac monitoring, so on a telemetry monitor in hospital. And that's just so that we can monitor, as I said, looking for this progression of this AV block. If the patient is symptomatic or they start having high-risk features on telemetry, we may need to put in a temporary permanent pacemaker to ensure that that patient is safe as they receive their treatment for Lyme carditis, and we await the serological testing. If we get confirmation by serological testing that the patient has Lyme disease, we generally will keep patients on IV antibiotics until they get their native rhythm or their normal heart rhythm back, at which point we'll switch them over to oral antibiotics. We say here that the total course should be 14 to 21 days, but I would say in general practice, we err on giving patients a full 21 days of antibiotics. And that's a combination, as I said, of intravenous initially and then oral antibiotics after that. Once the patient goes back into a normal rhythm, meaning that for every beat coming from the top chamber of the heart, there's a beat coming from the bottom. So that's what we call one-to-one conduction. We then evaluate them with stress testing, and that's usually on a treadmill. And we use what's called a modified Bruce protocol. It's just the protocol we use for the treadmill to ensure that they can continue having a normal rhythm with exercise. And what we're looking for is that the heart rate can stay in one-to-one conduction over 120 beats per minute. So if that's the case, we know that the patient can be discharged safely. If they're unable to do that, so if they can't keep a one-to-one conduction over 90 beats per minute, generally they need a permanent pacemaker. That's a sign of significant inflammation and issues with the conduction system. So they'll generally go right for pacemaker. If somebody kind of falls in the middle, typically we can monitor them, we can repeat the stress test and assess whether or not they need a pacemaker. But most cases that we see, as long as the patient is treated with adequate antibiotics, they never need a pacemaker. And that's a point that we'll kind of emphasize going forward. We've known for some time that permanent pacemakers are generally not required for patients with Lyme carditis. This is a table that was extracted from some research from 2018. And what it showed was a case series of 5 patients, and none of these patients required permanent pacemakers. All of them responded very well to the antibiotics. All of them within 10 days, but you can see that there's a couple patients that even within 2 to 3 days of receiving antibiotics, they went back into their normal rhythm. So antibiotics are crucial, obviously, in these patients. Unfortunately, though, there are circumstances in which the diagnosis gets missed and patients do receive permanent pacemakers to treat their high-grade AV block. I like to think in Kingston, we're pretty well aware of Lyme disease, Lyme carditis. And so, I haven't witnessed myself any cases of this where patients have inappropriately received permanent pacemaker devices, but we do see them coming in from peripheral centers where they've been put in, because they didn't suspect Lyme carditis as the cause of the AV block. This is really important because permanent pacemakers, they are associated with some short-term and long-term complications. And just recall, a lot of these patients that have Lyme carditis are young, they're otherwise healthy, and we don't want to put in a device that they absolutely do not need. And so if a patient does unfortunately get a pacemaker, we have published another case report, a case series in which we publish an algorithm on how to safely remove a pacemaker that's been implanted. So basically, if the pacemaker is in situ, we will interrogate the pacemaker in a device clinic to make sure that that patient is not relying on the pacemaker at all. If there's no ventricular pacing that we're detecting, that's great. We move on to the next stage. We put them on a treadmill, similar to our last algorithm, and we make sure that with exercise, they can maintain this 1-to-1 AV conduction at a heart rate more than 120 beats per minute. And if they're able to do that, we know that it's safe from a Lyme carditis perspective to explant that pacemaker. If they can't, then we do keep the pacemaker in place and try to re-stress them again in another 4 to 6 months. And our hope is that with time, perhaps maybe some of the inflammation in the electrical conduction system will settle down and we could eventually explant that pacemaker. If somebody's had to have repeated interrogations and we still can't reach that goal of 1-to-1 conduction over 120 beats per minute, the pacemaker generally is left in. And it's important that this is kind of on the radar of clinicians early on, because within the first year of putting in a permanent pacemaker, it's generally safe to remove it. All the operator needs to do is provide some direct traction to withdraw the leads. However, if you kind of get over that 1-year mark, you have this chronically implanted device, and it can develop fibrotic lead attachments at the tip and throughout the length of the wire. And so that those attachments can be to veins and valves and various structures. And so it just makes the removal of a pacemaker more complicated, and it limits where it can be done. So there's only specific centers in Ontario that would provide this service because it is a little bit higher risk. So again, this just highlights the importance of, one, trying not to put in a permanent pacemaker, that we all have a high degree of suspicion that somebody presenting with conduction abnormalities may have Lyme carditis. And it also highlights the importance of really close follow-up for somebody that has had a pacemaker put in. So we've spoken a lot about conduction defects associated with Lyme carditis, and this is fair because it is the most common cardiac manifestation. However, there is a much more rare but important presentation of Lyme carditis, and that's Lyme myocarditis. And myocarditis is a term that implies inflammation of the myocardium or the heart muscle. And myocarditis in general is what we would refer to in cardiology as it's a chameleon. And that's because it is caused by a number of diseases and infections. And so we really need to put our detective hats on when somebody presents with myocarditis. Typically, patients with myocarditis in general present with chest pain. They can present with arrhythmias, electrical problems, heart failure, and shock. And that would be the same whether they're presenting with Lyme myocarditis or just myocarditis from another cause. So it's often challenging to make the diagnosis up front. The most common cause of myocarditis is generally viral. And so a lot of the constitutional symptoms that we see with Lyme carditis are also seen with Lyme myocarditis. And although it's not validated, we find that the silk score is actually very useful if we have a patient presenting with myocarditis and they're young, because it just gives us, some sort of, it just puts our thinking hats on that maybe there's some clues that this could be related to Lyme. And again, I think if you're getting somebody who's scoring intermediate to high on the silk score, you should be sending Lyme serology for sure to make sure that this isn't Lyme myocarditis. One specific feature to Lyme myocarditis that could kind of tip you towards it would be if there are any conduction disturbances. So if there is AV block, I think you should be thinking about it a little bit more. The gold standard for investigating myocarditis is generally an endomyocardial biopsy, but these are a little bit higher risk, and you do risk missing the inflammation and the spare sheets that you could see. And so a lot of times we used advanced imaging techniques, specifically cardiac MRI, to see if there's any sort of late gadolinium enhancement or signs that there's inflammation within the heart muscle. Unfortunately, if somebody's presenting with a conduction block and they have a pacemaker in place, that does delay us getting an MRI because they can't have one. It's a contraindication if they do have a pacing device in place. And we know that over time, if we delay getting the MRI, we kind of lose sensitivity in picking up these subtle changes within the myocardium. And so that would be sort of one of the downsides of MRI, is if we have to wait to get one. All patients generally would get an echocardiogram as well. And the main thing that we're looking for here is looking for any left ventricular dysfunction, so heart muscle dysfunction. Patients, they should be in hospital for probably about 48 hours at least, depending on their stability. And that's just to make sure that they don't develop any of these conduction abnormalities or they don't have any progression to heart failure. Again, antibiotics are the cornerstone of treatment. And then we would generally treat heart failure and arrhythmia similar to other causes of myocarditis. Most patients should recover and feel a little bit better after 2 to 4 weeks, but we often will tell them not to engage in any sort of strenuous physical activity for at least 3 to 6 months. And that's just to allow the inflammation in the heart muscle to settle down. We also recently published a long-term outcome study, and for this study, we're looking at patients with serologically confirmed Lyme carditis from our center, and we look specifically at 7 patients following them for a mean of 21 months. All of these patients had been treated according to the protocol that we reviewed earlier in this talk. And then just some general aspects about the cohort. So they were mostly male, so 6 out of 7 were male. And they had a median silk risk score of 7. During the hospitalization, only 2 of the patients required temporary pacing wires, and 2 of them did have some abnormalities on echocardiogram. So this could suggest perhaps some underlying myocarditis from their Lyme carditis. The average time to resolution of their conduction abnormalities was about 3 days. And after the 21 follow-up, all of these patients were asymptomatic and they had gone back to their usual physical activities and usual activities of daily living. And so I think a couple things to highlight here is one, the usefulness of the algorithm that's been published, as well as the importance of early antibiotics for these patients. This is just a progression of the ECGs for all of the patients that were followed in this study. So you can see at the beginning, at admission, all of them had conduction blocks, so AV blocks. And for those of you that aren't physicians, what we're looking at is for every tiny little bump here, that's called a P wave, there should be a QRS complex or a big spiky complex that follows. But if you can look at some of these tracings, there are more P waves than there are spiky QRS complexes. And that's a sign that there's AV block in that AV node. At discharge, all of the patients had gone back into a 1-to-1 conduction, but there were a couple patients in which their PR interval was a little bit prolonged. So that's a first-degree AV block, which persisted on discharge. But the good news is after the average of 21 months of follow-up, all of these patients had gone back into a completely normal rhythm, and there was no AV block at all. Last year, we published a paper as well, and this was a paper that we collaborated with the Mayo Clinic and Johns Hopkins University, and we published it in Trends in Cardiovascular Medicine. This project was a systematic review and a meta-analysis, and we explored the association between late disseminated Lyme disease and dilated cardiomyopathy. So a dilated cardiomyopathy is weakening and dilation of the left ventricle, and it's generally thought to be something that can occur acutely, but you can often pick these up kind of later down the line as well. And Borrelia, we know that it was first isolated within the myocardium back in 1991. And since that time, there has been some speculation that perhaps Lyme carditis can lead to dilated cardiomyopathy, but it's kind of been with a lot of controversy. For the purpose of this systematic review, we looked at 11 studies specifically, and the inclusion criteria are listed there. Basically, again, we're just looking at the association between Lyme and dilated cardiomyopathy in humans specifically. And we define dilated cardiomyopathy as a left ventricular ejection fraction less than 40%, and or endomyocardial biopsy histology that was consistent with Lyme carditis or dilated cardiomyopathy. So 7 of these studies did report that there was an association between Borrelia infection and dilated cardiomyopathy development. One study by Klein et al., they examined the prevalence of antibodies to Borrelia, and they looked at 42 patients with dilated cardiomyopathy. And on ELISA, there was 26% seropositivity rate. Similarly, a study by Gazer and al., they found that there was a 24% positivity rate as well for patients that had dilated cardiomyopathy and a history consistent with Lyme infection. More recent studies have been using PCR analysis of the endomyocardial biopsy specimens to identify Borrelia in patients with dilated cardiomyopathy. And so Palachuk and all, they actually noted that 21% of patients with dilated cardiomyopathy were found to have Borrelia genome on PCR or electron microscopy analysis of the biopsies. And so we're looking at, 1 in 4 potentially could have perhaps a Lyme etiology for their dilated cardiomyopathy. So that's pretty significant. I should mention that many of these studies that found the positive association were completed in Europe. And so there are different species of Borrelia there. So that may be a factor. Only one of the studies was actually done in the United States, and it was one of the ones, unfortunately, that didn't show an association. So I think there is a lot of opportunity for research in this area, and it's something that our lab is looking into. Interestingly, of the studies we looked at in the analysis, 61% of them actually administered antibiotics to patients with suspected Borrelia-induced dilated cardiomyopathy. The most commonly used antibiotic was ceftriaxone 2 grams, and they administered that for 14 to 21 days. So similarly to how we treat the conduction abnormalities we see from Lyme carditis. Of those studies, 67% identified evidence that the cardiac function and functional status of the patient improved with antibiotics. And there was also some evidence that there was reversal of some of the cardiac remodeling in response to antibiotics. We think that, given this, the real incidence of dilated cardiomyopathy and late disseminated Lyme disease is probably underreported. And this is basically due to lack of long-term follow-ups on patients with Lyme disease and Lyme carditis. And so, as I said, it is imperative that we look at performing more longitudinal studies, specifically looking at Borrelia burgdorferi, which is more prevalent in North America as a causative agent for dilated cardiomyopathy. And it'd be very useful to perform some randomized controlled trials on patients with dilated cardiomyopathy and suspected Lyme carditis to see whether there is actually an improvement in left ventricular function with antibiotics. But again, I think, as we've highlighted throughout the talk, it goes to show that perhaps this wouldn't occur if patients had early treatment with antibiotics. Perhaps we wouldn't even get to this stage. And so again, lots of emphasis on thinking about Lyme carditis as a cause and treating these patients early with effective antibiotics. So what's next for Lyme carditis? So our knowledge of Lyme carditis is very rapidly evolving. There are several areas concerning the future of research into this disease that are worth discussing. So first, Lyme disease prevention and awareness remains probably the most important aspect of our focus. The development of a safe and effective vaccine should be available for people living in endemic regions who have frequent outdoor activities. At the same time, it's important that there's good social media campaigns, promotional campaigns that are And these are critical, obviously, to increase public awareness and lobbying efforts. The next thing would be focusing on prevention of Lyme carditis specifically. And we believe that all patients presenting with Lyme disease should be assessed with a full cardiovascular physical examination, as well as a 12-lead ECG. We do believe that the traditional prevalence of 4 to 10% of Lyme carditis is probably underestimated. And this is because many patients could actually be asymptomatic and have conduction abnormalities that just aren't being picked up because they're not receiving an ECG. Would it change their trajectory of the disease course? Potentially not if they're being treated with appropriate antibiotics, but it may. So we would like to do more research into discovering what the true prevalence of the disease is. We also need to recognize that Lyme carditis may have long-term effects on the heart in the form of dilated cardiomyopathy, as we just discussed, especially if it's not adequately treated on initial presentation. And so again, we're working on research models to look into this concept and trying to help design medical strategies to avoid long-term consequences of the disease. Research is also ongoing to identify autoantibody biomarkers of Lyme carditis in order to stratify affected individuals based on their risk of having a sustained immune response and potential cardiac involvement. And so this would help to facilitate proactive treatment and monitoring of these patients, as well as developing more precise medical therapies for them. And so just to kind of wrap up the talk here, we're just about done, but I just wanted to put in a plug for our upcoming publication. Dr. Baranchuk and Dr. Nancy Wang and I are in the process of finalizing our textbook called Lyme Carditis from A to Z, which will be published with Springer, hoping near the end of 2023. And it's a very exciting textbook. We have multiple expert contributors involved with this project. And I think it will be just a great resource for anybody who's working in endemic regions, just to reference and to look at some of the new and upcoming research coming up on the area. So please look forward to that going forward with the end of the year. But thank you very much for having me, and I'd love to take any questions or comments that you guys have.
Thank you so much, Dr. Wambolt. We can move right to the chat because I do see there's 2 questions that the audience has put in. The first question is, did you see in Lyme patients with chronotropic insufficiency when tested on a treadmill?
So, I haven't personally seen it. And, some of the research that we have done, and we've done multiple case series, we haven't captured it in our lab. So it is possible that if there is ongoing inflammation in the conduction system, that we may see issues with patients mounting that sort of response. I haven't personally seen it myself as of yet.
Thank you. Our next question is, how often do patients with Lyme carditis test positive for Borrelia burgdorferi, or is the bacterium long gone before carditis is ever diagnosed?
Yeah, that's a really good question, actually. I would say many of these patients, they're often presenting, I would say on average, 3 weeks to about 3 months out from their initial infection. And most of the cases that we see, we do have them test positive for Lyme, for Borrelia burgdorferi. So we do get a very high positivity rate. I myself have tested a couple patients who have tested negative initially, and I've gone on to test them again, and they haven't come back positive. I'm thinking one specific case of a young woman with AB block who we were highly suspicious because she had a tick bite only 3 weeks prior, and she presented with AB block, and unfortunately both of those serological tests did come back negative. But because of our high index of suspicion, we did continue on and treat her for the full course, and it didn't reverse. I think the message that I want to send is, if your suspicion is high, there is no harm, and I mean, there are harms associated, I suppose, with administering antibiotics long term. But if your suspicions are high enough that you think that this is an infection with Lyme, that you should treat it appropriately. And I think that's just because we want to prevent some of these long-term sequelae that may be possible from the infection.
Thank you. That is all I have in the chat box. I'm happy to turn it over to the audience. If you have a question for Dr. Wambolt and would like to ask her, feel free to raise your hand icon or unmute yourself and ask your question. We do have a couple more minutes. Just checking the screens to see if I see any hands up. Not seeing any questions from the audience. Do one more check to see. Oh, we do have a question. Go ahead, Cindy.
Thank you. Could you just address or readdress what you would do for patients who have had Lyme for, say, 4 to 10 years, and they start to develop these heart issues? What sort of antibiotic treatment would you recommend for these long haulers?
Yeah, so I think that's challenging because it's an area that we don't obviously have a lot of research in at this time, and that we obviously need to fill that void. And so I think the main thing I would suggest is if the patient is presenting with dilated cardiomyopathy, meaning that they've got left ventricular dysfunction less than 40%, and you've got this very clear history of Lyme exposure. Again, we don't have the evidence to back it up. It may be worth exploring that with like the local heart failure team to see what their input is. I think going forward, we're going to find that treating these patients with a course of 14 to 21 days of IV antibiotics of ceftriaxone could potentially be useful in these patients. So at this time, I can't give any specific recommendations because we just don't have the research to back it up, especially with Borrelia burgdorferi. It's kind of a watch this space sort of situation. But if you can't find another cause of their dilated cardiomyopathy, it may be worth giving them a 14 to 21 day course and see if there is any improvement. But I would say that's if you've exhausted. At this point, that's if you've exhausted all other potential causes of their dilated cardiomyopathy.
Thank you. Thank you for the question. Do we have any additional questions from the audience? No? One last time, going once, twice? Okay, well, thank you so much, Dr. Wambolt, for your enthusiastic and lovely presentation. We always enjoy having you and your team and Dr. Baranchuk on the call and helping us out. I see lots of great congratulations. So thank you again. I do want to remind everybody that we are continuing our series of talks tomorrow, and we do have Chang Zhengjiang, who will be presenting on the topic detecting Lyme disease sooner using proteomics to identify early biomarkers. And that presentation will be starting at 1 o'clock Eastern time. And Chang is part of Dr. John Frampton's lab out in the Nova Scotia in Dalhousie University. So hopefully you guys have an opportunity to join us tomorrow. I also want to remind you that we are participating again, take part in our challenge this year. Wear green, take a photo and share it with us to help spread awareness of Lyme disease and tick-borne diseases. If you don't like your photo taken, and I'm one of those individuals, and you are an artist, and you like to draw or do pottery or other great works of art, you can take a photo of your artwork that expresses Lyme disease and tick-borne disease awareness month, and that photo will be entered as well. We are having a draw of one of 4 $25 Starbucks e-gift cards, and the live draw will occur on our last day of our presentations at 1 o'clock on May 31st. And you can send your photos to clyderin@gmail.com. And finally, You're probably wondering, what is TICNET Canada? Some of you may have heard that the Canadian Lyme Disease Research Network is looking to evolve and also include other tick-borne diseases. And so we're looking to expand over the next few years into TICNET Canada. So we will look on doing research not only on Lyme disease, but other tick-borne diseases. And we will be hosting our first scientific symposium in person in Toronto this fall, October 24th to 25th. We're just working on the fine details with our planning committee. And registration and abstract submission will be opening soon. So we'll keep you posted, and hopefully by the end of the month, we do have registration open. Otherwise, for those of you that are part of our distribution list, we'll keep you informed via email when registration opens. So again, thank you, Dr. Wambolt, again, for your wonderful presentation. Thank you for the audience for taking the time today to listen. And we hope to connect and see you throughout the month for the rest of our presentations. Have a great day, and we will chat soon. Take care, everybody.
Thanks.